Good morning. I think without further ado, let's start with the next session. May I call upon our chairpersons? Dr. Namrata is not here. Dr. Bhalla is also not here. Dr. Sudhakar. Dr. Sameer Verma. Yeah, yes, sir, please. So the session deals with post-cataract surgery complications. And today we have a star-studded session, and our speakers will talk about management of the same. So our first speaker, Dr. Rajesh, I think, is held in some other talk. May I call upon Dr. Rishi, please? He'll be talking on management of post-op macular edema.
At the outset, I'd like to thank the organizers and JV Pharma for this session. This is a sponsored talk, and the slide deck has been prepared by the company, and I'll just be sharing it with you. So the idea of this talk is to kind of give you an insight into the role of Nepafenac 0.3% in the management of macular edema in diabetic patients undergoing cataract surgery. So why diabetic patients specifically? I'll make the case for that. Basically, cystoid macular edema is much more common in diabetic population compared to normal population, and this drug is specifically approved for that. So Ilevro from Novartis, which is now in India marketed by JB Pharma. So to give you an overview, there are 100 million people worldwide showing some signs of macular edema secondary to diabetes, and 1 in 3 people with diabetes have some evidence of macular edema. So that's a very, very common problem considering diabetes is an epidemic in India right now. 77 million diabetics in India have diabetic macular edema. 2% of them have diabetic macular edema. Around 22% of diabetics who undergo cataract surgery can develop macular edema. So that's almost 1/4 of all cataract patients who are diabetic will have macular edema. And I'm sure all of you who are doing cataract surgery, at least half or 2/3 of your list patients are nowadays diabetic. I'm sure you agree with me. So cataract surgery increases the risk of post-surgical edema or worsening of pre-existing edema exacerbated by pre-existing diabetic retinopathy. So if you have existing diabetic retinopathy, the risk becomes many-fold more. 68% of these patients will resolve spontaneously within 6 months, peaking at 6 weeks. Pre-existing macular edema, if it's present in patients with diabetes, will tend to have a worsening after cataract surgery and a more severe course after cataract surgery. This was a large study in UK, 81,984 eyes, which showed increased new onset diabetic macular edema post-surgery. So there was a 1.8 times higher risk of macular edema in patients who were diabetic without retinopathy, and a 6.23 times higher risk in patients who were diabetic with pre-existing diabetic retinopathy. So if you have pre-existing diabetic retinopathy and you're going for cataract surgery, there's a huge chance that you're going to end up with macular edema. So this subset, I think definitely one must use some sort of a prophylactic measure. And in general, I think all diabetics, there is a significant case for using prophylactic medication to prevent cystoid macular edema after surgery. What are the effects on vision? Significantly impairs the visual rehab after cataract surgery and affects retinal morphology and visual function. Excess intraretinal fluid can cause irreversible structural damage and permanent vision loss. So topical NSAIDs are an effective strategy to prevent post-surgical macular edema in diabetic patients, just like they are for all other patients as well. And we all know that. These are the mainstay of prophylaxis for cystoid macular edema. So what are the options we can use other than NSAID for preventing and managing cystoid macular edema after cataract surgery? Topical steroids can be used. They have lower penetration into the eye compared to NSAIDs, give superior results when combined with NSAIDs, but there is always a risk of raised intraocular pressure with the use of topical steroids. Lasers have been used for diabetic macular edema, enlargement of laser scar, transient increase of diabetic macular edema, accident foveal burns, or choroidal neovascularization can happen because of damage to the Brooks membrane, and that can permanently affect the vision, and even there can be loss of some lines of visual acuity. Triamcinolone acetonide has higher risk of increasing IOP, we know that, if you give an intravitreal injection. And other intravitreal steroid options are also available, which can cause risk of increased intraocular pressure. Not all patients demonstrate a response to anti-VEGF treatment, so it doesn't work in all cases, the intravitreal anti-VEGFs. And if they do work also, you may have to give a lot of injections sometimes. So what is the mechanism of topical NSAIDs? They block the cyclooxygenase pathway, reducing the prostaglandin production and vascular permeability, thus decreasing macular edema. Common NSAIDs that we use are nepafenac, diclofenac, bromfenac, and ketorolac. So preoperative use of NSAIDs is recommended in eyes without preoperative diabetic macular edema also to reduce the risk of developing diabetic macular edema postoperatively. So what is the case for nepafenac as a prophylactic treatment for macular edema in diabetic patients undergoing cataract surgery? I think this couple of randomized prospective multicenter double mask studies are a significant case. So the study 1 and study 2, you can see both there's a significantly lower incidence of macular edema within 90 days after cataract surgery in the study population which received nepafenac. Compared to the control population which received the vehicle. And the pooled analysis showed 4.1 in the study population versus 15.9% incidence in the patients who didn't receive any NSAID. So this is a statistically significant difference between the two groups, showing that clearly the benefit of topical nepafenac in preventing postoperative edema in these patients. And there were no unanticipated adverse events observed in these cases. How is nepafenac better than the other NSAIDs that are available in the market? It has been proven to be effective against pseudophakic CME development, increased target activation, greater duration of action, and I think this is the last one is the most important. It has very good permeability and penetration into the eye and reaches the retina better. So what are the key takeaways? Diabetic macular edema is accumulation of excess fluid in the extracellular space within the retina in the macular area. Approximately 22% of diabetic patients develop macular edema following cataract surgery. Nepafenac is proven to be effective in reducing the risk of postoperative macular edema in diabetic patients. Compared to other NSAIDs, nepafenac has higher permeability, greater duration of action, and increased target activation. Thank you.
A crisp and concise presentation. I have one question, sir. Practically, do you start NSAIDs in all your diabetics post-op, or is it dependent on the baseline sugars?
So earlier I was using them only for diabetics and patients who had like a traumatic surgery or where I was anticipating CME. But now I've made it a protocol for all my cases. I started a few days before surgery and continue till 6 weeks after surgery.
Right, thank you. Thank you so much. Yes, sir, please.
Do you feel by using diclofenac as tablet, if you use diclofenac tablet before surgery, along with the nepafenac, does it make any difference in results? Because it is written in the literature that diclofenac tablet, if you use before the surgery, then it reduces the chances of macular edema in general.
I think prophylactic oral NSAID, why do you want to unnecessarily give it? They have their own side effects. They have renal toxicity and gastritis. So maybe for the pain, if you're giving it, it's fine. But I don't think prophylaxis of CME, it makes it.
Anybody else is aware
I'm not
of
aware
this?
of.
Yes, it
the
is mentioned.
literature.
I read in the John L. Parr, textbook of intraocular lenses by John L. Parr. He mentions that studies are there that if you use diclofenac tablet, 100 milligram tablet, a day before the surgery, if patient needs antacid, you can give antacid. Rather, with all the NSAIDs given orally, one has to give antacids. Otherwise, they may cause micro ulcers in the intestines. That is not a problem, but it does reduce chances of the macular edema in general.
Anybody who is following this practice, no? Rajesh sir, would you comment on this?
Doing systemic NSAID. Yes, earlier we used to give, even for, when somebody developed macular edema, then we used to give Indocap SR and all those things long back, many years back. But these days, in our practice, we are not giving systemic NSAID. We are not giving that. In high-risk cases, not in all cases, we give NSAID topical as well. But yes, in high-risk cases, post-uveitic or any complicated scenarios, we like to give topical NSAID in these patients.
Right.
Point 0.3 is one time a day, Nepafenac. If you're using concentration of 0.1%, it's 3 times a day. And if you're using 0.3%, it's once a day. Yeah, that dose will not change. Thank you.
Thank you, sir. So Dr. Rajesh will be talking on prophylaxis of post-op endophthalmitis. Over to you, sir.
Thank you very much. A very good morning to all of you. Endophthalmitis is one of the dreaded situations, complications that can happen in a case of cataract, and we would never want to have it in our case. So we do take preoperative and intraoperative and postoperative measures in order to prevent endophthalmitis. Starting with the preoperative measures, one important thing is that if somebody is a diabetic, then the blood sugar control should be good. Otherwise, the risk of post-op reaction is high. The risk of flaring up of any subclinical infection is very high, and that can result in endophthalmitis. Of course, we should check that there is no regurgitation on pressure of lacrimal sac, and there is no discharge, there is no, and one should not do any contact procedure like biometry or tonometry on day of surgery. If there is definite redness in the eye on the day of surgery, if the patient has come to you and you see that the eye is red, chemosed and all that, then it should be avoided. And preoperative topical antibiotics, a lot of people give. There are indications, there are definite suggestions also in literature which states about the role of preoperative antibiotics. But of course, the biggest role is of povidone iodine before the surgery. If that should definitely be put in the eye before, or first of all, you should clean the lashes and eyelid, and then of course you should put it inside the eye. As far as the intraoperative measures is concerned, we should have adequate OT sterilization. The proper OT should be there. It should be sprayed, and OT sterilization should be maintained. A regular culture should be sent from the OT so that you are sure that there is no organism growing in the operation theater. Sterilization of instruments should be adequately done. And I'm not going into details of all these because each topic in itself is a single talk. So I'm just covering up the basic heads. And of course, there are monitors which will tell you that the instruments are properly sterilized, and this is always there. You can use disposable instruments, which is something which can be of great use. A lot of companies are coming up with disposable, irrigation aspiration probes and blades, etc. And that does not, that takes away your headache of sterilizing the instruments. Anything that goes inside the eye, like phagotape, sleeve, cannula, should be changed for each case. Adequate hand washing should be done. If you're using betadine or chlorhexidine, then it should be, scrubbing should be done for 3 minutes. If you're using liquid soap, at least for 5 minutes. And bar soap should be avoided, and water should be clean. And proper gowning and gloving should be done. There is a proper etiquette for that as well. I'm not going into it, but yes, the gown should be properly sterilized and mask should cover the nose. Sometimes you see that people have their mask coming down, which is not acceptable. It should cover the nose and mouth properly. The OT cap should cover the hair completely. There shouldn't be hair coming out of the OT cap. That's very important. And the position of the hands after scrubbing and gloving should be above the waist. And the patient hygiene should also be maintained. Patients should be told to clean their hands, face, and then of course betadine cleaning with 10% betadine should be done of the lid, lashes, etc. And then once that is done, when the patient is on the table, you should put 5% betadine in the eye. It is very essential to understand this thing because many times we get the supply of 10% betadine. We should dilute it to 5%, otherwise it does cause some surface toxicity, 10% betadine. So when we are instilling into the eye, it should be 5% betadine and it should be kept for 1 minute. Sometimes in some of the countries like in UK, even double contact with betadine is done in order to prevent endophthalmitis, and it has a definite role. Of course, the irrigating bottles should be separate for each patient. That is very essential. You should always keep a sample of the bottles of that batch that has been used, because if there is any infection that has happened, you can send that that fluid for culture, and that can save you, because if there is anything wrong in the bottle, then you can always say that in the code of law that it was not exactly the surgeon's fault, it has come from the company. So that is also something that will safeguard your interest. And of course, intracameral antibiotics, which has become very popular these days, it should be used at the end of the procedure. So once you hydrate the wound, hydrate the main wound, and the side port as well, after that you inject into the bag. You try to push it towards the IOL so that the intracameral antibiotic remains. And which intracameral antibiotic, that is an important thing, important issue. Intracameral moxifloxacin has now become very popular, and it is used worldwide because of earlier we were using vancomycin. So this is how we just push it fast so that it goes in towards the bag, and that is the end of it. So earlier we used to use this vancomycin, but then there were reports of necrotizing retinitis and all those things, so that's why vancomycin is no more used. This is a very good study done from our own, from India by Arvind Eye Hospital, and this is analysis of 6 lakh surgeries, wherein half of them were injected intracameral moxifloxacin, 0.5%, 0.1 ml. That is important. 0.1 ml of 0.5%. And half of them were not injected moxifloxacin. And they found out that there was a significantly lesser chance of endophthalmitis, occurrence of endophthalmitis in eyes wherein intracameral antibiotics were given. So they found out that the overall endophthalmitis rate reduced by 3.5 folds, 3 folds for manual SICS and nearly 6 folds for phacoemulsification. And they also saw that in cases where there were PCRs, posterior capsular tears, in such cases, wherever intracameral moxifloxacin was given, there was much more reduction in the chance of endophthalmitis, and that is why the study strongly recommended that intracameral moxifloxacin should be given in eyes wherein there is a PCR, and of course, it should be given in all the eyes because it reduces the chance of endophthalmitis. Well, there are people who are still not giving worldwide, but that is a different issue altogether. But if these things have come in literature, and if you don't put intracameral moxifloxacin, then in a court of law, if there is an endophthalmitis, then if you have put it, then that will be an extra safeguard for you. You can always say that, yes, we have followed all the norms that are there in the literature. And as I said that, intracameral vancomycin, which was used earlier in the fluid, there were reports of hemorrhagic occlusive retinal vasculitis, and that is why now intracameral moxifloxacin is being used. This is another study which has shown that intracameral moxifloxacin is non-toxic and safe, but the dosage should be 0.1 ml, 0.5% solution. Now, this is the ACRS clinical alert, and it was an advisory that was released, and it was published in the year 2023 in JCRS. It has been done by a good friend of mine, William Myers, of course, in association with a big shot of cataract surgery, Dr. David Chang. And they did this advisory because they found out that moxifloxacin is being increasingly used, and there are two different concentrations available, 0.5% and 0.1%. So what should be the dose? Because if you inject more, then there is risk of TAS. If you inject less, then then it is ineffective. And that is what they did. And they finally published the report in the JCRS in the year 2023, and they reported that 0.1 ml of compounded moxifloxacin, 0.5% solution, or they had used Vigamox, and or you can inject 0.5 ml of a compounded moxifloxacin, 0.1% solution. Whatever you use, it should be either 0.1 ml of 0.5% or 0.5 ml of 0.1%. Because if you increase more, if you inject more, you can have TAS. And any additives, if they are there in the formulation, then that can also cause TAS. And this is one report which has reported occurrence of TAS, and they reported that it was because of the installation of higher volume, that is 0.6 cc of 0.5% moxifloxacin. Another study showing efficacy of moxifloxacin in preventing endophthalmitis. And of course, in the end, wound security is very important, so we should have a watertight wound. And in case you see that there is any leaking wound, then in that case, don't hesitate to put suture. So in conclusion, endophthalmitis definitely is on decline. Long time back, we used to know that it was 0.1%, then it reduced to 0.2%, now it has come down to 0.07%, and it is all because of all the measures that we are taking. Of course, intracameral moxifloxacin is a very important tool, very important step to prevent endophthalmitis, but the most important thing, once again I would emphasize, is use of povidone iodine in cul-de-sac before the surgery. That is again a very important step. So thank you very much for your patient listening.
Thank you, sir. So what is your take on pre-op syringing?
Sorry?
Preoperative syringing, sac syringing.
See, if there is no discharge and if there is no regurgitation, Roplast negative, then there's no need to do syringing in all the cases. Only if there is watering or a little bit of discharge, if you have some doubt, then only there is need of syringing. Otherwise, it should not be done.
Even for one-eyed patients?
Even in one-eyed patient, if there is no discharge, no watering, nothing, then there is no need to do syringing. Roplast negativity is something which is a very important step. Yeah.
I think very nicely expressed the emphasis given on the use of intracameral moxifloxacin, because there is always a confusion. People use various regimes. Some use topical antibiotics few days before surgery. Some use topical antibiotics 2 hours before the surgery, very frequent dosing. But it has been published that if you give pre-operative antibiotic topical drops, the concentration achieved in anterior chamber is just 2 microgram per ml. Whereas if you give intracameral moxifloxacin, as very nicely explained by Professor Rajesh Sinha, you achieve concentration, intracameral concentration of 950 microgram per ml, which is more than 10 times the minimum inhibitory concentration, because you want to retain this concentration for 4 hours after the surgery with half-life of about 4 hours. So this is well established, and all these guidelines, ASCRS guidelines, ESCRS guidelines, now there is a SAGAR guideline by Australia also, which has clearly established that the intracameral moxifloxacin should not be given in high-risk patients, that is one-eyed or having PCR, but it should be routinely given in all your cataract patients. And this has been nicely emphasized in the study by Haripriya et al. In JCRS, who has done study on consecutive 6 lakh patients. I think very nicely explained, sir.
Thank you.
So now you can call that.
So I welcome Dr. Mohanta for his talk.
Good morning. My respect to all of you. I am going to show the use of pre-chopper in management of soft cataracts. So, it's not running? Okay. The pre-chopper goes through the main wound, and through the side port is the nucleus sustainer, which supports the nucleus. So the pre-chopper engages just in front of the rhexis margin. Let us see some videos. The pre-chopper goes, the nucleus sustainer supports the equator. The two instruments come to each other and we do lateral separation. And one heminucleus is divided and the other heminucleus is also divided. This procedure takes about 30 seconds. So just imagine how much ultrasonic energy we save. And it is safe. The nucleus sustainer is a ball-tipped instrument, and it doesn't cause any rupture of the posterior capsule. And the nucleus and the pre-chopper is also having a blunt posterior end. And now just rotate the pieces. We don't have anything to do. Just go into the anterior chamber and start picking up the pieces and emulsify them. So this is the ultrasonic energy is saved so much, and there is no chance of PC rent. The chance of PC rent is reduced. We know that chance of infection increases manifold if there is posterior capsular rent. This is another technique another case after rhexis, hydrodissection and hydrodelineation is done. Once we get a golden ring, the nucleus sustainer goes just beyond the golden ring and supports the nucleus. The pre-chopper goes, and the two instruments meet each other and we do lateral separation. 3 fragments, and this is the last fragment. It takes only 20 to 30 seconds, and we save a lot of ultrasound. We don't cause we don't try to hold the nucleus to chop. We know that in soft cataracts, the PC rent usually occurs when we try to hold the nuclear mass at the periphery. We just eat up the matter. Along with that, we just touch the posterior capsule and we make a hole in the posterior capsule. So if we pre-chop the soft cataracts, we decrease the chance of posterior capsular rent, and we can manage such cases very easily. This is the technique of removing the cortex by the handpiece. It has some learning curve. You just finish up everything and come out. And this is the last case. This is hydrodelineation has been done. Nucleus sustainer goes. The pre-chopper is engaged. This case is, we can say this is grade 3 nucleus. We can do anything in this case, but to save ultrasonic energy, we can pre-chop such nuclei also. We have made 3 fragments. This is the last fragment. So 4 pieces have been done in less than 1 minute. We save a lot of time, lot of ultrasonic energy, less chance of posterior capsular rent, And we can use this technique particularly in weak zonule, in subluxated cataracts, where if we try to hold the nuclear mass, we tend to hold the capsule and the bag. So if we pre-chop and emulsify 3 pieces, and for the last piece, if we do the IOL scaffold technique in weak zonule or subluxated cataracts, we can. This technique also helps in floppy iris. So this is the pre-chopper technique for soft cataracts. Thank you very much.
So this looks so easy and smooth in your experienced hands. What would you tell the not so experienced people? Do you think it's easy?
Yes,
for them?
it is not difficult. Everybody can try. Just imagine this is the nuclear sustainer. This is the bend. From the bend, this is 1.7 millimeter. And I have designed another one that is 1.9 millimeter. It goes like this. In the anterior chamber, it turns like this. Then you hook the equator. This movement has to be practiced in 4 or 5 cases. And the nucleus pre-chopper, it just goes, and in front of the rexis, it turns and engages in the soft part. So pre-chopper goes and engages here. The nucleus sustainer goes, turns, hooks the equator. 2 instruments come to each other and separate. Just these simple movements have to be practiced in 4 or 5 cases. Thank you.
Dr. Pradeep, so what is the grade of cataract till
You
which
try
you can
this
do?
in grade 2 first.
Grade 2
in
to
grade
3.
2 first, it will be very easy. And then you try in grade 3. And in hard cataracts, please don't try this. The nucleus will turn this way and that way with hard cataracts.
And one thing I noticed was that it will be better if we don't do hydrodissection. We do only hydrodelineation. Because with hydrodissection, your nucleus will not be stable. It may move, it may rotate once you are doing these 2 maneuvers.
We do hydrodissection, no problem.
do
with
hydro.
that. We hydrodissection and hydrodelineation.
Both.
If you do hydrodelineation, you get the mark where you have to engage the nucleus sustainer.
Okay.
Pardon? Yes, it is available with me as well as with Joja Surgicals.
I think anyone interested can contact Dr. Pradeep.
Pradeep, yes.
Thank you.
The ideal stage of rexis can vary from 5 millimeter to 6 millimeter. Initially, you do a large oval rexis with vertical axis from main incision to the opposite equator, so that nucleus sustainer get space to hook the equator for first few cases. And Anurag, I want you to try this.
It's a very elegant way. I think Dr. Pradeep made it look so easy. Wonderfully done. Congratulations, Dr. Pradeep.
Dr. Jenin is not there.
So we'll have Dr. Vardhaman Kankaria, and he needs no introduction. He's going to talk on post-refractive surgery biometry. Dr. Vardhaman.
Thank you so much, Dr. Bhalla sir and the whole team, Dr. Namrata ma'am for the kind invite and the opportunity. So friends, what I'm going to talk to you about is something which is extremely relevant to each one of us today, because this is about something that we are going to see more and more number of patients coming in for our clinics. And we all are going to be dwelling with these issues of biometry after they have undergone their previous refractive procedure. Friends, we know that it has been almost a century before the first ever attempt of corneal refractive surgery was done by Professor Sato in the former posterior RK about in 1920. And from that time to current generation of laser refractive surgeries, we have truly come a long way. But I think this was in 1990 when the first global phenomenon of acceptance of corneal refractive surgery happened around the world. And this is when the patients actually tested the miracle of this amazing, miraculous procedure which can get rid of your glasses without any pain, without any not much post-operative recovery time, with a great amount of wow effect, and this became extremely popular around the world. And so far, multiple millions of people have undergone LASIK surgery in the world. Now, the first generation who had actually tested the success of this miracle was what is called as the baby boomer generation. This baby boomer generation as of today are the same people who have become 60, 70-year-old, and they are the ones who are coming back for their post-LASIK cataract surgeries, and they are the ones who have a extremely high, unusual expectations. They have relatively low intolerance for diminished vision. They are the ones who will request you for early cataract surgery. And they will be very demanding because they have tested the accuracy of LASIK and they would like their cataract recovery to be as good as LASIK procedure. However, the issue is that in the very patients who desire the most accurate post-operative refractive results, the IL calculations are unfortunately least predictable, because of variety of factors which happen in the form of 3 different errors in calculating the biometry. Before we go to our current generation formulas, let us understand how the biometry works in virgin eyes. We all know that when it comes to virgin eyes, there are 2 different generations of formulas. The first one is called as the regression analysis, which is dependent on the accumulated data. And the second one is more recent, it is more predictable. This is what is called as the theoretical formulas, which work on the principle of what is called as effective lens position. Effective lens position is the difference in millimeters between your anterior refractive surface of the cornea and the nodal point in your crystalline lens, or the IOL which is going to go inside and sit in the back. It was presumed in the past that this effective lens position will be 4 millimeter as standard, but then it was seen that in shorter eyes, the ELP is shorter, of course, and in the longer eyes, which are myopic, the ELP is going to be longer, and this had to be counterfeited, this had to be adjusted. So this prediction of the effective lens position became the cornerstone of the accuracy of the current generation formulas, and these all formulas depend on more than 1 parameters to predict ELP, as we have seen. Now let us see how and why the IOL power calculations are different and more difficult after their excimer laser applications such as PRK or LASIK. So there are 3 different sources of errors which happen. Number 1 is called as the index of refractive error, that is calculation of K reading. Second one is the measurement error, that is on topography and keratometry you have errors because of the previous LASIK surgery. And the third one is the prediction in the ELP, which happens because of the errors in the formula in itself. We all know that whenever we actually want to understand the diopteric power of the cornea, this is a very specific equation, and the ratio between the anterior and the posterior surface of the radius of curvature of our cornea, which has to be maintained at 1.21, and that is the whole basis of the calculations of keratometry in our current generations. However, when you undergo LASIK surgery, we know that the cornea on the anterior surface becomes flat, so there is going to be overestimation of the keratometry, thus causing underestimation of the IOL power, leading to hyperopic surprises in patients who have undergone a myopic ablation in the past. And opposite to that, if you have undergone a hyperopic ablation, the cornea becomes steeper, so therefore your keratometric prediction becomes underestimated, your IOL power becomes overestimated, and therefore you land up in having myopic surprises after your IOL calculations in cataract. Second one is the topography or keratometric measurement error. We all know that the most important point in keratometry is the central point, this one. But majority of these keratometers and topographers actually do not calculate the keratometry in the apex of the cornea or the center of the cornea, but it does it at the zone which is 3.2 millimeters away from the center of the cornea. And the second one and the third one, of course, is going to be the prediction of the ELP errors, which depend on the formula. We have all seen that these ELP prediction models work on variety of parameters which had to be utilized to get to a good IOL power calculations, and all of them, except for one, depend on keratometry as a prerequisite. So if you look at all this keratometry, wherever you're using this keratometry, and because the keratometry calculations are going to be erratic, you're going to actually have a lot of surprise also in the formula. But when you use the Haigis formula, you see that Haigis does not depend on keratometry, and that's the reason that in Haigis you actually still achieve a good outcome with post-LASIK situations. So generally what we have seen so far for patients who have undergone a myopic treatment, they will have a overestimation of keratometry, they will have an underestimation of ELP, leading to underestimation of IOL power generally. And the hyperopic patients who have undergone LASIK in the past will actually have an underestimation of keratometry, overestimation of ELP, leading to overestimation of IOL power in general. So when we understand that these are the errors, how do we still go ahead and calculate the lens? And as we have lens power, and we have seen already that the Haigis L formula is K independent formula, and that's the reason that you can still go ahead and use a Haigis L formula if your biometer has the direct access to Haigis. But if your actually biometer utilizes the other keratometry-driven formulas, then you have to go and use what is called as the Arambedi double K method. This Arambedi double K method uses two different keratometers. Number one is the pre-operative keratometer determination that is used to predict the effective lens position, and the true post-operative keratometer measurement is done through pentacam and to be used in formula for calculation of IOL power. And when we use this Arambedi double K method, definitely you achieve a very, very predictable outcomes. There have been variety of formulas. We have used these two different approaches and they have seen almost equally predictable outcomes, and they all have been coalesced together in this wonderful website on ASCRS online calculator. And all of you can go there, you can put the type of refractive surgery that has been done on the patient, any pre-operative or current data that you know already about the patient, you can enter that as well. The IOL power is calculated by a variety of these formulas, and those requiring also historical data and those do not require historical data. And it will give you three readings. One will be minimum, one will be average, and one will be maximum. And that is what you have to utilize. There have been a lot of different studies which have looked at all these formulas, and they have seen currently the OCT-based and the TrueK methods, which is by no history, are currently one of the best formulas which are used currently. With all these things in place as well, unfortunately, the patients who have undergone RK and PRK are still getting good results, but the patients who have undergone radial keratotomy do not achieve good outcomes because they have also a lot of corneal instability. And in spite of the best analysis, we have seen that only 65% cases are plus minus within 1.5 diopters. Let us look at this case in which we can see the cornea is very, very flat. The patient has undergone a 16 incision radial keratotomy. The keratometry has dropped to 29 diopters. And you can see on the IOL master, the calculations are varying between almost 17, 18 diopters to 19.5 diopters. And this is a nice method that I use. This is called as a Maloney's method, in which you can do the intraoperative retinoscopy and then have a multiplication factor to come to your IOL power. And in this particular patient, we actually could come within 1 diopter. And so far, we have done 38 post-RK patients with the same method and achieving 90% of our eyes plus minus within 1 diopter with this technology. We have also seen that if the patient has undergone previous intacts because of the keratoconus, you can still go ahead and use the post-myopic formula on the ASCRS. And the most important thing is that for the patient who has undergone a phakic lens implant, you do not have to make any adjustments whatsoever if you want to do biometry for these patients. So that is the crux and the simplistic approach to these patients. But for sure, I do expect more and more of us are going to come ahead and they are going to do post-LASIK keratometries and biometries in the future. And I hope that this helps all of them. Thank you. I think we would like to know the comment from Dr. Harbansh Lal. Thank you so much.
One of the most elaborative, topics in ophthalmology, and 10 minutes don't do justice to it, but you've done so well.
Thank you. Thank you so much.
Yes, sir, please.
So I think there are two things.
Yes, sir.
One is that take the flattest corneal measurement available in all the possible equipments used.
Yes.
Whether it's a pentacam and whether it's a LenStar IOL master.
Right.
And it is not always the pentacam gives the flattest. I've seen patients where the LenStar and IOL master have given the flatter as compared to the pentacam reading.
Right.
Secondly, in all the irregular cornea, refraction of the patient is more important than the calculation by any other machine. That means if the post-RK patient has got a hyperopia of 5 diopter, so we target -1, take it as a hyperopia of 6 diopter, multiply it by 1.7 or 1.8.
Yes.
That means when you multiply 6 into 1.7, it makes it 10.
Yeah.
21 is the normal IOL power used. This patient should have 31 diopter of IOL in his eyes.
Right.
If all other calculations, some calculations given 20, if they are coming around 31, it's fine. But anything is coming 22, 18, 16, 36, 37, you got to be very, very careful. And even for the astigmatic correction, in my post-RK patient, whatever patient is accepting on the spectacles is the more important, whatever reading you are getting on a pentacam and a biometry. So all the astigmatic correction should be done on the basis of the spectacle refraction and axis. You will never go wrong.
So I think all these points are very important, as sir has said. Number one is that you should, if you have access to multiple instruments, it always is better because you can actually understand how the corneal keratometry especially are varying between all these instruments. If you go flatter, as has been discussed, always is in your favor because you would like to have a myopic error rather than having a hyperopic error. And using the calculations, that multiplication which I have also showed and sir was also talking about, of 1.7 or 1.8 comes very, very handy. And having a good retinoscopy, like somebody who can do a good retinoscopy in your center is
there
very
is a
crucial.
difference what we are talking of the intraoperative.
Yes.
I am talking preoperative. In average eye, the IOL power needed is 21. If the patient is hyperopic by 5 diopter,
Yeah.
so the same 1.7 or 1.8 you multiply, add into 21. So it's very difficult to do the intraoperative refraction and then try to calculate. So, and secondly, whenever you do the piggyback IOL,
Yeah.
or when you're adding on, it is 1.7.
Yes.
Otherwise, even 1.7 as Maloney will not hold true. Just I'm coming to the point.
Yeah.
Reason is, we have done a lot of cases in a camp, and normal IOL required is 20.5 or 21 in the Indian eyes. And while after leaving the patient aphakic, patient needed plus 10 or 10.5. That means whenever there is absolutely no lens inside the eye, it is the multiplication factor is higher. It is reaching nearly 2. So whenever the refractive error is more, even multiplication factor is also higher. As compared, if patient has got 2 diopter of refractive error, you can multiply by 1.5, there is no problem.
Yes.
If patient has got 8 diopter of refractive error, you will have to multiply with a higher factor.
So the only one thing that probably I'll not agree with you will be about the preoperative refraction when the cataract is still in the eye. Because when the cataract is still in the eye, the nuclear changes in the cataract is going to change your refraction. It is also going to change your astigmatism significantly. And if you take the axis
So
of the
most
preoperative
of
refraction,
these
make
patients are
all issues.
myopic.
Yeah.
They always come in a very early stage, are not yet operated, a post-RK patient who has gone into hypermature cataract stage. And secondly, all these patients have got a history along with them. They are very clever, they will give you all the sheets of the refraction they have been using over the period of time.
Yes.
So even you can find out whether it's a nuclear sclerosis changing or their refraction is stable what it was there. So you'll always find out in a post-RK patient or post-LASIK patients, they never come too late. There's always a immature cataract.
Yeah, so the prerequisite here is that you should have the history of the patient very well. Even patient has developed the cataract. Because many times these patients will come to you after they have developed the cataract and done the refractive surgery somewhere else. So I think, yeah.
They have got their spectacles along with them.
Yes.
I think, Vardhaman, there's just one other thing that in my hands, in my experience, the Barrett's True K works a lot better than the high gaze. The high gaze
Yes,
is
yes,
a K independent formula, all right, but it has just too many variables when it comes to the A constant. It's not easy to compute the A0,
A0,
A1, and
A2.
A2.
Very true.
So
very
high
true.
gaze is one of the best formulae to work with, the pre-Barrett's era, if you have all the parameters with you.
Absolutely.
Because there's just too many variables which we don't have any clue about.
Yeah.
And for Intax, I actually don't change the formula at all because it doesn't, apart from flattening the cornea, it doesn't actually change the shape or the contour of it. So you can go ahead and do it in a normal way. For the post-RK, however, if we are trying to correct the astigmatism in particular, most of the time, as the topography would reveal, they would not have regular astigmatism. So if the patient has a history of using glasses for the astigmatism and the patient is happy with it, I would much rather put in a spherical IOL and ask the patient to continue wearing glasses to correct the
Absolutely.
astigmatism and
I
not
think the
try to correct
regularity-
it with torics.
Regularity of the cornea is very crucial in
If the
pentacam.
patient is happy with the cylindrical correction, he'll be happy with the cylindrical correction, the IOL as well. So the cornea is so distorted, so when the patient uses spectacle in whatever axis, the same axis will work in the IOL. So next time you try it out, and most of the patients usually will find will come within 0.75 to 1 diopter. If you correct by, I have used plus 9 diopter of the power and corrected 6 diopter of astigmatism in these patients. Leaving the patient 5-6 diopter astigmatic is not the option.
Yeah, I think every case in these cases have to be done with individualistic approach.
Individual.
Vardhaman,
of course.
yeah.
There is no one fit approach. Yes.
We'll have to wind up. I think it was very informative for discussion. So many points got clarified because the post-refractive surgery IOL power calculation is always an enigma. So with that, we now come to the last talk by Dr. Anurag Mishra from Bhubaneswar, and he's going to talk on very important topic, physiological IOP phaco emerging trend in cataract removal.
Thank you so much, Bhalla sir. Thank you so much, panel. Good afternoon, ladies and gentlemen. Greetings and regards from the land of Lord Jagannath. Now, I'll try to expand this topic in the form of a few FAQs that I very commonly come across when I present about this in different podia or even during live surgeries. The first of this question is, what is physiological IOP? What is low IOP on the phaco machine? What low IOP should you set, and how low is low? When we transgress or make our transition from the gravity-dependent machines to the active fluidics machines like the Centurion, most of us use the IOP of, say, around 80 because we've been used to hanging the bottle at around 100 centimeters height. Any value lower than this can be considered low. Most of the surgeons are happy in the 40 to 50 range of IOP while operating. But if you talk about physiological IOP, it should be somewhere around 20, 25, 24, 30. Set your comfort level, but it should be somewhere around 20. Now, the question is, if you bring down the IOP on a phaco machine and operate under physiological conditions, so to speak, is it truly beneficial to the patient? There have been several studies which prove that it lessens the injury to the corneal tissue, the endothelium in particular, because you're not bombarding the eye with fluid. It reduces post-operative inflammation, reduced blood flow in the chororetinal vasculature. There's no increased stasis in the vasculature, reducing the chances of post-operative CAME, NAION. All these, to me, are theoretical. Let's talk about something very, very practical. Aren't we all, as ophthalmologists, always believed in the rule of the min, the rule of the minimum? When we correct the myopia of a patient, the correction we give, is it not the minimal correction on the spectacles which achieves 20/20? Do we go to the max correction which gives 20/20? When we correct glaucoma, the target IOP achieved with a minimal amount of drop combination, isn't that the regime that we select for that particular patient? When we do a PRP, don't we apply the minimum number of laser spots that achieves the job, that does the job for us, and not go and char the retina all around? And when we do a corneal suturing in case of a perf, don't we apply the minimum number of sutures which achieves the wound integrity and not go on decorating it with sutures all around? So if we believe in all these principles, we do believe in the rule of the min. So the minimum numerical value of the IOP set on the phaco machine, which keeps the whole environment under physiological conditions, is it not beneficial for the patient and the surgeon combined? But the question is, if you go down and liberate less amount of fluid from the phaco machine, how is it possible that the anterior chamber will be maintained for you and offer you sufficient space to do your job? So what the manufacturers have done is, there's a very tiny laser etched spot that looks like a QR code of sorts on the FMS of this machine. Now the manufacturing plant, what they do is they produce IOP fluctuations mechanically or artificially. The response of the machine is then recorded. Because it's an active fluidic system, the bag is pressed between two plates to liberate more fluid. Every change encountered and every resurrective measure that is taken by the machine is recorded and etched on onto this mark. Now, the moment you fit in this FMS into the machine, there's a blue light, there's an optical sensor which constantly looks over this. So if there is a minor fluctuation, the IOP drops a little below the preset value of 20 or whatever, then the machine starts acting immediately. And on top of that, nowadays they have an active sentry, which is an irrigation pressure sensor built right into the handpiece. So that's very close to the business end. The moment there's a fluctuation in the irrigation, it takes the measures again. Do we need to tweak other indices? If we are operating under extremely low physiological IOP conditions, do the other parameters need to be tweaked? Yes, they do. The vacuum should be set somewhere around 400 to 450. You can't say that I operate under 20 and go to 600 plus. You're bound to have surges. Even the aspiration flow rate should be bent down. It should not be set at 35, 40, which we are mostly used to. It should be brought down to 23. But the question is, if we are using such minimal fluidics on the machine, does it slow us down? Does it slow the procedure down? We'll see that in a moment from now. But there are certain other surgical factors also that you need to modify. The main port incision should not be less than 2.2 because if it's less than 2.2, it kind of constricts the sleeve and liberates even less fluid. Side ports should be as small as possible. The sleeves should get changed with time because with time, with repeated autoclaving, they swell up and cause a rigidity. And kinking, while you're introducing the handpiece, the sleeve gets kinked at times. That should be checked because the fluid you're liberating into the eye is very, very low. Now, slowing us down will be demonstrated. It's not something that you should see. So this is an unedited video. The only thing that has been cut is the changeover time from the phaco handpiece to the eye and all that. So this is when I start. The IOP is set at 20. You can see the flow rate is at 23. The vacuum's at 445. And I initiate chopping. This is the primary chop. Would like to repeat that this is an unedited video, so one should actually keep a check on the stopwatch if one's having access to it. The primary chop complete, the secondary chop initiated, the other side of the heminucleus. All right throughout the type of nucleus and the type of case and the type of patient I handle, the IOP stays at 20. I never ever increase it to any other value. There might be some other changes in the dynamics part though. For the harder cataracts, the torsional energy might just go up a little. The IP settings might change a little. It might just give me a more bulk of part to boom the nucleus with, but not the fluidics part. So this is where we are closing in on the nucleus. The epinucleus is there, and then the cortex. All that will be removed in one go after that. So this doesn't slow us down. The next question, due to paucity of time, I have actually cut down on a lot of videos. But just to answer this question, does it work for all cases? As I explained, it does work for all cases for me. And I deleted a lot of videos due to paucity of time. I'll just pick up one which is really, really hard. And as I said, the IOP stays at 20. The only thing that has changed right here, if you could see from the last case, is the VAC has increased to 500 and it has not stayed at 450. So the vacuum has increased to 500 in this case. And the torsional power now scales up to 70, particularly for the chop mode. The longitudinal phaco essentially is 0, and the IP settings have changed a bit. I would not like to take you to the details of the IP settings and where I keep them for harder cataracts because it actually needs some amount of understanding. But again, if you look at the CDE, there also I'm acting like a miser, not spending a lot of energy. And we are through with the chopping almost, and the CDE has essentially stayed less than 4, which is actually commendable for any procedure, because for a cataract which is of this sclerosis grade, which will be close to a 4 or a 4 plus, any CDE, if you're managing the whole case with the CDE being kept below 15 or 16, you must pat your back saying that you've done a good job, son. So we are into the quad mode already. Again, an unedited video. I just wanted to show you that neither does it slow us down, nor it forces us to expend more in terms of energy and fluidics. Even the last piece doesn't have to be handled in a slow motion because you do not see the anterior chamber flinch at all. All this with low fluidics and low IOP set at 20. I'll stop at that. Thank you so much for your kind attention.
Always a pleasure, sir, to listen to you. I just had one question. Is there any case scenario where you would, kind of increase the pressure?
So it doesn't depend on the case, but it might depend on the patient. Some of the patients are very apprehensive. They hold their breaths. Some of the patients have deep set eyes. And if you have, that's the reason why I do not use the self-retaining speculum. I use a wire speculum. So if you're using a self-retaining speculum on a deep set eye, it kind of puts a positive pressure from the anterior side. But that's rarity. What's more common is a patient who is more apprehensive and holds its breath, and there's an internal pressure that builds up. So in those circumstances, you might just need to scale up a little and go up. But 20 can increase to 30, and that's maybe in a 0.1 to 0.2% of my patients. And then less, 99.8, it stays at 20.
Thank you, Anurag. I think that was very nicely explained, because we have been traditionally using gravity-dependent IV poles and oblivious of the fact that a bottle height of 105 centimeter causes intraocular pressure close to 77 millimeter mercury, which is pretty high. It may not, if the surgery is fast, it may not amount to much in normal patients, but imagine such high pressure you are maintaining in patients of moderate to severe glaucoma. You may be happy with having done very good surgery, but post-operatively you will find that the field is really being affected to a great degree.
Other
Yeah.
practical point is, sir, with the advent of modular OTs coming in, most of the roofs will not allow you to keep your bottle height at 105 centimeters. That's
But
a practical
even 90 centimeter is equivalent to 66. So that is pretty high. So if you want, like you are working at 20 millimeter of mercury or 30 millimeter of mercury, imagine having double that IOP. That really is very detrimental. I think very nicely explained this concept. Thank you.
Thank you.
So with that, we come to the end of this session. I'll request all the speakers also to come for a group photo. Pradeep, Dr. Rishi is there.
I think they've left for the other session.